right? So we're going to look at all of those things. We will spend some good time talking about the acne, talking about if it's mild, moderate, severe, and specific findings that are associated to those things. We're going to talk about some of the perioral dermatitis, acne rosacea, the Dennett's, super miliora. We're going to talk about some of those antibiotic stuff that we will need to push out. Pseudomonas barbae, the keloids, which look EICs, and pilar cysts. So let's talk off first with all of the acne vulgaris, right? So we know that we've got that of a multifactorial disease of those sebaceous, of the pilosebaceous unit. Oftentimes we see these things start happening once a child gets into the puberty, okay? Variants on severity, again, like I said, we're going to talk about mild, moderate, severe. Happens with not one, but both of the sexes. If your mom and dad had it, if other siblings grew up with it, then it's probably going to happen to you as well, okay? 89% of the profile, again, 12 up to 24, which we talked about the puberty and that the growing, and then it's even more or less happening with us older folks. Good thing I only have a 3% chance, but I've never had it before, so it's good to go. 3 components. So this is that etiology. So we could have some excess of sebaceous gland secretion. Again, we can have that the pilosebaceous duct obstruction. And then we get into that bacterial of that the colonization and inflammation. So if it's some of the bacteria that we think, then we're going to prescribe some stuff and we will list those out. I just like Doxy. So that's one of those things that are on there. Okay, once we treat that, we see that it is Propionibacterium acnes, and so that is P. acnes. That is what's causing it. That is the bacteria that is associated with acne vulgaris. Breaks down of the sebum to free fatty acids, which are irritating and cause that inflammation. So if we get into the aspect that we believe it is some of that the P. acnes, then we are going to treat. Here's a picture showing those different types out there. Okay, so mild, moderate, severe. We're going to look at another chart that's going to give you key components of what they are different about. Okay, so early, late, inflammatory stuff, and then we get into that nodular cyst that is out there. Again, that is of that the classification, right? So if they're not having any inflammatory process, those are those open the comedones or the closed, right? So that is the white or black, right? That's what that is out there. However, if they start to get into some inflammatory process, then you can have some of the papules, you can have some of the pustulars. If it's getting severe, then you can have those of the nodules and cysts that are out there. Again, here it's showing you types of the lesions. So you've got that non-inflammatory process. So those of the comedones. If it gets inflammatory, then you can see some of the papules and of the pustules. But if it's getting severe, then you'll start to see those nodules. Yes, we can see some of the nodules. We can see the pustules and of the papules in both of those moderate to severe. But the numbers, you can see it at the bottom. So you got those pluses, right? They are all different. So if it's mild, papules, pustules, we see 1 to 2. With the nodules, what's it say? 0. So if it's mild, they don't have any nodules. What is specific about a nodule? You can see it, but is it open? Is it that? Is it outside of the skin, or is it up and under the skin that is causing that? It's up and under, right? So if you see more of the nodules, then you're progressing on. Moderate, we can see that of the nodules, 1 to 2. Severe, 3 plus. So they have so much out there. But again, you can see some of the papules, some of the pustules. Okay, looking at that middle picture, you can see like one nodule that's down at the jaw line, but the other things that look, that's the papules and the pustules. Whereas on severe, you can see a lot of the nodules out there, right? So there's no pustule onto them, that's just throwing it out. So know those numbers. Diagnosis, typically a straightforward clinical diagnosis based upon the presentation. When you're looking at it, that is where you're going to make that decision. Differential diagnosis, we're going to talk about these things, right? So we have to look into those aspects that are pertinent to of each of the diagnosis. Okay, so we're going to talk about rosacea, folliculitis, the PFB. Okay, we're going to get into those ones there. So let's get into the treatments. Patient-centered. Okay, what have they tried? For how long have they tried it? Right. A lot of the individuals start off, if it's looking open or the closed the comedones, mom and dad are going to go buy something from Walgreens or CVS, right? They can try some of those things. So how long have they been using that? Okay. We always have to remember, even if it gets into severe, moderate, right, even mild, if they've tried all this kind of stuff and it's not going away, then it can be some of the psych stuff, right? Like they're embarrassed with it. They skip school, or I don't want to go to prom, or yada yada. Okay, so that's the thing that we might have to look into as well. If it's not fixing with that OTC stuff, then we got to do something else. Okay. If it's of a mild, then that would be some of the treatment first. But once you start some of the medications, have them follow up with you so you can see if it is. We are going to have the follow-ups after and after. We've tried this and this and this. Where are we going to send them to once we've tried and tried and tried? Derm. Okay. Type and number of lesions direct the trauma, which is treatment. Trauma. Treatment, okay? So basically here are some of those things that are specific to things out there, okay? So modifications, mild soap and water. Frequently we have to do those things to try over-the-counter stuff. Exfoliation, mask and peels and lotions and washers, washcloth. This is all of the stuff that they have probably tried and started on. Avoid further occlusion. Oil-free, no makeup, okay? No the oil, no hats, if that's part of it that's causing it to happen. Avoid stress, caffeine, high sugar of the content foods. No problem avoiding stress in puberty. Is that a joke? Yeah. Yes. Okay, because let's take no out of it, because it is problematic avoiding that stress with them. So here's therapeutic targets that are breaking it down into what is out there. So if we're talking about that initial stuff, so we're seeing some of the comedones, whether it's open or it's closed, then we can try some of the retinoids. We can try some of the peroxide, salicylic acid, azelaic acid, alpha hydroxy acid. And I mean, if you're trying all of that stuff and it's not getting any better, then we can think about some of that Accutane if we need to send them over. And we're going to specifically talk about Accutane here in a little bit. Again, the generic name of Accutane is what you see there at the end. So that's isotretinoin. Okay. If we get some of that bacterial stuff, of course, number one, we got to start some of the antibiotics. We can use some of the benzoyl peroxide and we can use some of the retinoids. Sebum production, retinoids, we can get into some of that of the anti-androgens, so low dose of an OC. What's an OC? Birth control, right? So we would be using that, of course, with our females. Inflammation that is not going anywhere, we can do some of those antibiotics, and we can talk about some of the retinoids. Which type of a medication is in every one of those things? All right. Here's of a thing here that is showing around just some of those areas. Okay, where is that of an inflammation? So what could we look into? If we're doing some of the antibacterial, then we can use those ones and up and above, right? So we can see those things. Now we're going to get into the each ones, right? So we're going to talk about mild, moderate, severe, and we're going to get into these things here. So non-inflammatory of the comedomal. Start with the retinoid. Okay, start low, go slow. The most common retinoid out there is what is listed here. So you got that tretinoin. Again, it talks about the dosages, but y'all know I've already told them that I would never ask you those things, just the name of it. Okay, slow upward titration and avoid irritation and increase of compliance. Okay, when are we going to be using these things? Bedtime, right? We can also add some of the benzoyl peroxide, which we'll see that on everything. Topical of an antibiotic, if we think that we need to throw some of that out there. Benzaclin, if they're doing that, then we can go ahead and give them some of that benzoyl peroxide. We see there that the benzacline, if this is the comedomal non-inflammatory, it's talking about the Clinda. Not only are they always going to have them on that retinoid, if it's working, then we can increase it when they follow up with us and then try and shut it down. Run it away. Again, we always have to be patient. So, non-inflammatory. Okay, this is still acne. Does it bother, like itching and stuff? Yeah, it could. But it's likely not going to happen just because of the fact that it is anti-inflammatory. So, open ones and closed ones, those are out there. Again, here's more of those open and the closed ones. So it's non-inflammatory acne. So up on the left, that is open. On the bottom right, that is closed. So blackheads, whiteheads. Now let's get into those three types that we saw on that slide way back in the back. So mild inflammatory acne. What's it say like the other one did? Start with a retinoid. Okay? So, and or benzoyl peroxide or topical antibiotic. You are going to see this slide specifically talking about the mild, and it says or, right? So it's not using them all, it's saying because this is mild, let's start with the retinoid, and or we can add some of this and we can add some of that, those things out there. We'll be using these on not every night, but alternate evenings for the first 2 to 4 weeks to allow that patient to adjust, because it will be causing them to have some of the irritation. So it's not going to be using it every single day. That's not only for this one, but those things, it's going to go on for that same exact thing. Always have them follow up, right? Because we have to look at that, see if we need to increase or if we need to decrease, depending on what their presentation is. Consider adding of the oral antibiotics if after follow-up we're still having some of those, the pustules, then we need to get into that, right? It's got some of the clients out there, but I told you a little while ago, I like Doxy, okay? Typical starting doses, and then we might need to adjust with their age, with their weight, with their follow-up, how effective that is there, okay? At least if we're going to use some of those antibiotics, it's not just going to be of a week. We're going to get up to at least 3 months for us to see where we're at. So here's some of that mild. How many of the nodules does mild have? 0. Do you see any nodules up there? No, we're seeing some of the pustules, okay? We see some inflammatory process, but it's not as severe as it's going to get once we get into the next 2. So, mild, okay? Moderate. This doesn't say and, this doesn't say or, like it did with of the mild. It says all 3, okay? All 3. So starting again, it's the same medications that we talked about with of the mild, but these are different one or the same ones, but there's no or. We're going to throw all 3 at them. So the retinoid, the benzoyl peroxide, antibiotics. Again, it gets into one of those medications, and y'all know which one I like. Okay, taper after 2 to 4 of the months if improved. If it is okay, then it would be some time for us to at least take that antibiotic off, but we will still stick with those other 2. Consider intralesional steroid injection for stubborn nodules, because moderate does have some nodules, right? It's not a lot as it is with severe, but they are there. So that is used with some of the triamcinolone, okay? Again, most oftentimes this is done by the dermatologist, but if you are in a wonderful clinic, or if you become one of the derm ones, then you can actually do those things by yourself. So you can, and I've done it before, but it's, you know, you could also refer them out. Moderate to severe. If you're trying those 3 all put together and it's not getting any damn better, then we're going to send them off to derm, because the thing that does work is Accutane. Again, Accutane is only prescribed by a dermatologist. It's got significant side effects, one of those including teratogenic. What does that mean? It's going to not be bueno with that fetus, right? So once it's in there, Accutane can say bye-bye. But also you see the mood swings. Accutane is very effective. It helps them out. We're not going to send milds to throw them through that with all of the side effects that could be potential. But once it's moderate, severe, and we've tried and tried and tried, Accutane will improve that. Again, they have that I pledge, so they, you know, I state your name, da 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 da. So like you have to go through those things so that you know that I won't do this and this and this and this. In women, we can, but the dermatologist will always make sure that they're on some type of a BCP so that they're not getting into some of that teratogenic. Okay, spironolactone, that's one out there, but if I've already sinned and they've already done of the pledge, they're not going to be on that one, which I don't know why it's on this slide because I would delete. Other options, okay? We can talk about a retinoid. We can talk about an antibiotic, of the combination products, other of the oral antibiotics, and then in Habib it lists some of those things out there. But those are ones that we can use to treat, but that's one of the things that we have already tried. Accutane it is. Okay, so off you go. So here is moderate. Okay, so we can see some of the pustules, we can see some of the papules, but we can also see some of the nodules, right? So y'all can see the nodules up there, like right over here. It's not having any of the pustule, but we're having some of those things out there, okay? It's not a lot, right? Because with moderate, we usually have how many types of the nodules? 1 or 2. So right there is one. We can see one over here, but everything else is all of those pustules and those things out there. So a quiz. What do y'all think that one is?
Non-inflammatory.
What? Non-inflammatory. So we would call that what? The comedomal, right? We can have that be open or closed. So it's non-inflammatory, just like y'all said. Okay, what does this one look like? Mild, right? So we've got mild there. We don't have any of the nodules. Yes, we can see some inflammatory process that's there. So we've got of the redness, but that's still up on top. That's of the epidermal area. It's not down deep and pushing it up and out. Okay, what do we call that one? I think we just saw the picture. All right, so that one is of the moderate. Okay, I haven't talked about this one yet, and it's coming up after this, so it's not check on learning, but what do y'all think this looks like? Yeah, so we're going to get in now, talk about severe. Okay, so you can see all of that all over. You can see nodules, everywhere. Okay, so that's what it's looking like. So when we're talking about severe, basically we can call it nodule cystic acne because they've got the nodules going around everywhere. We don't see, we could see some of pustules, but more associated with severe is that nodules. Morphology-wise, significant inflammation, papules, pustules, but in bold we see those nodules, cysts, scarring. Next of a line there talks about sinus tracts. So this is one just flying over to the next one and the next one back and forth so they can have those tracts that are causing that. They'll also have that edema. Those are the things associated with that severe. Face, neck, chest. One of the most important aspects of severe is that it could be on the back also. Okay, so it's spreading around so you can see that out there. Usually family history, most of the times we see these in the males. Again, we're already sending them out to Derm. I won't even try those top 3. If I see it and I know that this is nodular cystic severe acne, I'm just going to refer them right away. Okay, I'm not going to go through, hey, I'll give you retinoid, antibiotic, benzoyl peroxide. Like, I'm not going to say, let me try these things. I'm going to say, you're off. Okay? Often embarrassed, like I said earlier, missed school, they missed work, depression, anxiety, they just hide because of the fact that it's all out there. Okay, again, you can see all of the nodules up there. Okay, do we see a bit of a pustule above it? Yeah, well, the one on top by her eye, you can see it's got a little bit of the pus, but it's going on of the cheeks, nodular, 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 chin, like it's everywhere. So they've got that. The other one is of the back, so you can see that, okay? It's got some of these special of the names that are out there. It's still severe acne vulgaris. It's still that, but these are specific terms that just describe them. That upper back is, it's bad. Okay, so that's why they call it the conglobata. Again, I'm all about mild, moderate, and severe. Okay, that's another one there. Another special name called the pyoderma facial. So that's rosacea plus severe acne. So what would let us know that she's got some of the associated rosacea? Well, it's called rhinophyma, right? So that's her nose that is blowing up. Okay, so that is everywhere. What do we think the treatment is? Like I said, we're not going to jump into any of those, of the top three of this and that. We're going to already refer them over if they haven't already been there. Like an ER would already say, hey, you need to go to dermatology. Okay. So again, Accutane works by reducing the size and activity of the sebaceous glands. Very effective control and long-term remission. We talked about that significant side effect profile, and we'll talk about those again. Intralesional steroids for large nodules. Again, we already referred them to the dermatologist, so those individuals can use that. Intralesional, that triamcinolone. This one of the Accutane, it affects all four of the therapeutic targets. So it'll treat the comedone genesis, of the sebum production. They'll get into that bacterial stuff, right? So that pseudo of the acnes. I don't think it says pseudo. So what it said back there, okay? Inflammation. And again, we need to use this for nodular acne, if they had it before, but then it went away, but it's back. Okay, well, we need to get back on the Accutane. Okay. Up next, we're talking about the screening of the patient. These are some of the things that y'all will start. So if I refer them out, I'm going to go ahead and start some of the baseline labs or other things out there, so that the dermatologist already has it at their, they have it, so they can then start the medications right away because you have already done it, okay? Once they're over at the Derm, they will, start off in a quicker follow-up, but once they're on it and, it's just watching it out, that is every 6 months, okay? With the Accutane, they have to discontinue of the tetracyclines, of the topical retinoids, and all of the vitamins, especially vitamin A. Okay? I talked about the labs before. So CBC, UA, LFTs, lipids, HCG. Okay? Again, I don't know what other test questions you've had in the past, but this is a list and only one is going to be on there, okay? So know them all. Repeat labs before each follow-up. Women have to get that HCG every month while they're going through these things, okay? Even if it is finally turned off, they're going to have it again because it's still in their body. If it is the tetragenic, then of course they can put them on 2 methods of the birth control just to make sure that we're not having that to go on. Loose association with the Accutane is that IBD. So do they have it or does their family have it? So that's one of the things that we look into, okay? So overview of instructions, okay? So emollients and moisturizers will be used as well as that. Go ahead and use that oil-free moisturizers. And wear the sunscreen if you're out and it's causing that kind of stuff, right? We have talked about that a lot, and we'll talk about it in block 2 once we get into all of the lights. Lubrication for the lips, eyes, and of the nares. Watch for mood swings. Avoid excessive alcohol. It says excessive, so it means you can have a beer or a wine, but just don't get blasted, okay? Part of the reason why we have the LFTs that is on that the labs. Dispense only a 1-month supply to women of that childbearing age to make them come back, okay? So I want you to come back in the 30 days. You will be running out of the medication, and I'm going to do HCG on you to make sure that you are not having any type of the pregnancy. And again, I'm not sure why we would ask this, but if they're having Accutane put in there, I don't want your blood, okay? So no blood donation during treatment. Why would we have to stop it? Well, if we get that HCG and we find out that that female is pregnant, then we're going to stop it just because we want, or we do not want to put them through the tetragenic aspect. If they're having some of signs of ICH, right? So headache with the visual changes, headache not relieved by the OT meds. What is ICH? Intracranial hemorrhage. Yeah. Okay. Good. Y'all know all of this good stuff. Perform retina check, right? So if they're having some of those things there with ICH, we always do look into the eyes. Mood swings, suicidal, homicidal, ideation. So if they're having SI, HI, like with everything, right, regardless of what the medication is, we're still going to get into that, but that's one of those things that can be caused by Accutane. All right, so what's this one? It's on all of the back. Probably if we were turned around, we can see some of that stuff on the face. So this is nodulocystic. So yes, severe. There was a special term for this one that had that word that starts with a C. Yes. Okay. Again, I told y'all I'm going to stick with mild, moderate, severe as opposed to beautiful, wonderful names. So, adult female acne. So this is just breaking it down into if it is of the female, okay? Those happen mid-20s to late of the 30s. Of course, they're sensitive to some of the hormones that are out there. It flares up with menses, like a lot of things happen, right? So if they have this acne, then it can be worse of a flare. If they are pregnant, then it can pop up, right? Because y'all have so many changes of everything head to toe because of that beautiful fetus that is up inside of your uterus. They have a few of those of the tender lesions and slow healing, but they're out there, okay? Morphology, very inflamed red papules and the comedones, occasional small non-scarring cysts. Usually this occurs on of that chin and of the jawline. They can also get it on of the neck, but location of the chin and jawline is one of the top ones. Management-wise, if they are not pregnant, then we can use some of the oral of the contraceptives. With this one, within they're on of the oral of the contraceptives and not what? Accutane, then we can use some of the spironolactone right here. There's also that retinoid. There's also of an antibiotic. Okay? Those are those things that are out there. When we're talking about those OCPs, then we will talk about those suppressive of excess ovarian androgen production. So it's talking about orthotricycline, talks about estrorostep, Yaz, Lornia, Nikki. It's called Nikki. Okay, good. Minaj. Bayez. Okay. Once we do that stuff, then we can get into the spironolactone, and that's what we would be one of those other things out there. Okay. So that is all of the acne stuff, right? So we talked about a lot. But there were key components that I threw out to you, and y'all will remember those things. It's been 40 minutes, but I still have slides to go through, so we're going to press up until 10:50, and then we'll take a break, okay? Perioral orificial dermatitis, okay? Again, this is a part of the differential diagnosis, not only in block 1, but we're going to get to some more ones in block 2, and of course this will be part of that. But this one has a basic component that will be seen on every patient in every picture, and it's that bottom line bolded, okay? There is a clear zone around the vermilion border. So where's that at? We're seeing it all in here, and it's not going to go all the way through that. So this is a key component to the perioral dermatitis. Sometimes it's a little bit closer, but you can't see that it's not all of that upper lip, okay? So let's talk about the clinical presentation. Most common in young women. It'll have some of that mild itchiness, recurrent, so if it goes away, then it can come back. Normally fair, delicate skin. Morphology-wise, you can have some of the papules and pustules, and that's why sometimes the differential diagnosis will be acne. Typically confined to the chin and nasolabial folds. Where is that at? Exactly where they have that of the picture. It's just outside, so it's right up in there. Pustules on cheeks adjacent to those folds and highly characteristic. Again, occasionally red and scaly. So that's a beautiful mustache, but it's not all the way down to that vermilion border. Unknown. Why is this there? Okay, well, they could have some type of using some of those moisturizing creams that Sephora wanted to have them buy. Okay. Patients may have tried self-treatment with topical steroids, benzoyl peroxide, but that's just causing it to happen. Again, y'all know all of the medical history. That includes us asking about what of the medications that they're on, even if it is over the counter. And then if they tell you, okay, well, stopped at Walgreens and I thought I could use this or this. Yeah, no, okay. What are we going to do? Okay, well, stop. facial moisturizers and the cosmetics, okay? Both Sephora and Ulta are gonna you up, okay? So let's not do those things. What's a medication? My favorite, Doxy, okay? Sometimes requires a longer of a course. So it talks about, okay, we're gonna do that for up to 2 to 4 weeks, have them follow up. If it looks like it's better, but it's not all the way gone, okay, well then we might need to just extend it a little bit more. Literature supports the use of topical erythromycin gel or metronidazole gel twice daily for 8 weeks in mild cases. However, clinical response will be slower than with systemic therapy. Basically, let's not use erythro and let's not use metro, okay? Let's go ahead and stick with the Doxy. Does it spare that vermilion border? Yep. Is it all the way to like the right or left? No, but you can still see that there is some of the clear zone. That one shows you all over. So there and there. Okay? Any questions about the peri-oral? Cool. Acne rosacea. So we talked about this earlier, right? When we were seeing some of that, the acne severe, that it can actually capture in and pull some of the rhinophyma. So we can pull in rosacea with it, okay? There is one thing out here that we haven't talked about with all of the other things, is that we've got that Demodex follicularum. So we've got that thing that is up and underneath of the skin that is causing rosacea to flare up. Okay? Morphology-wise, we got some of that erythema, papules, pustules, telangiectasis, swelling of cheeks and of the forehead, and then that enlarged nose. They're looking like a clown that's got a red nose. Okay? Rhinophyma. I don't even remember what that clown was. I was like on that show. Some of y'all were probably not even born because I was a kid, damn it. So that, yeah. Okay. Anyways, huh? Yeah. Okay. Acne rosacea. Oftentimes we will see this presenting to us with fair-skinned people. It happens in those high sebaceous areas, so the mid-face, specifically that malar area. So what is the malar area? Boom to the boom, right? So it's above or top of the cheeks. With rosacea though, because it affects of the nose, you will see it go up and into that there. Once we get into block 3, I'm going to be teaching you some rheumatic, anyways, rheum stuff like lupus that doesn't go up and over the nose. So this will, yeah. I hate that part of derm. Again, we can have some of that eyelid involvement. We can see it on the chin, on the forehead. We can have some of that flushing, just like we talked about before. ETOH can increase the erythema. So some wine, some whiskey, oftentimes you can have them present to you and say, like, it looks like this, but it only happens if I have a Whiskey Wednesday, right? Yeah, so it's out there. It also happens with the hot spicy foods, hot drinks, the caffeine, hot the climate, exercise if it's hot, emotions and stress, sun exposure. These rosacea can burn or sting. Again, because all of the alcoholics love this stuff, it can be 30% or 30 years old, 40 years old, Whiskey Wednesday, okay? Causes embarrassment. But if you're at Whiskey Wednesday, then you're not embarrassed because you're, woo! Management, if it's mild to moderate, well, let's avoid those triggers. The things that we just stated, let's avoid those things so that we can get it to go away. Sunscreen, right? Yes, you can have some of the sun exposure. You being outside, it can flare it up. Medications that we would use, okay? Flagyl, metronidazole, topical, BID. Why would we be using that? Because of that, okay? Because we know that this Demodex follicularum is oftentimes the etiology of why we're having rosacea. So how would we treat that? Well, we could do some of that flagyl, metronidazole. We can also use some azelaic acid. If we're getting into some type of an antibiotic, then we can get into the tetracycline. Refractory disease, so it's getting, significant, especially if their nose is, then we can get into some of the Accutane. The dermatologist can also refer them for some surgical excision to get that out. Okay, again, there's that mite stuff. This is, some of the mild aspect. It's not super of the rhinophyma, right? So we can see this of the malar area, but it gets onto the nose with acne rosacea, right? So it's on those malar, but then it spreads up and over the nose, okay? As seen here. Also, now we're getting some of that rhinophyma. It still see that of the malar rash, right? So it's on those upper cheeks, but now the nose is not getting happy, okay? Significant stuff. Rhinophyma. How many of y'all have actually seen this before where the nose is looking like this? If you haven't, you will see them now and be like, huh, rhinophyma. You should go see dermatology. That's a big one. Okay, let's take a 10-minute break and start back up at 11:02, and then we'll get into the next stuff. So we're almost there.
The reason I was raised by the television, it would come on TV. They did like a kid show, and you pretty sure like Nickelodeon.
That's so good. I don't think it would fly today. Yeah, there was all right.
Like a lot of these records, like they're back like.
The third one's called Three.
He was like a one of the actors who like programs back in the day.
I don't know. I've only watched it.
Showing your age.
You know both.
I know, I just.
Well, first and foremost, Nickelodeon was the OG. All the rest of them. But like basic television, particular parts of Network had to pay for it. Actually before that. So Disney came public TV. But on Nickelodeon. But then Nickelodeon kind of got outshone later on. But once Cartoon Network came available, it was great. It had the best shows. Because Nickelodeon went, because if you look at the ratings,
No, but I'm saying like if I'm not language things like that. No, it's just weird.
even if it's in fun, then that's why so like, I didn't want to watch
It's kind of like don't give me hope. Don't give me hope. Only from you. First of all, I'm not allowed to contact yeah, it's terrible. At 14, I'm gonna go my high. But right now, I'm enjoying it. There's like which one? I was like, there's two. There's three, really. I guess now. Lunch passes out. What is important to make sure your coworker doesn't leave? It is fun to like do like like it was like his
When I'm singing a lot, I'll get all. I play two
I never finished it, but I need to watch that. That episode is like independently the greatest short story. It's not much farther than that because I think the rest of the series is
One and two, both of them.
No, that was the biggest pyro. My brother wants like gives it. I downloaded it. I played it for an hour. I didn't get past the one thing. They go right to the front, and I just
Rob Street Smart.
Just give me a fun your little trailer that gets shot now? Yeah, I think that works. And I've definitely had to wait for it to take a while. What's that? Boom pump? I don't know why. I was going to say, she's had it. I'll send you replacement parts. You write out.
Alright, so let's get these last 60 slides so that y'all can have
Hey, y'all shut up now.
long lunch. Because y'all will definitely have that. So we're just going to talk real quickly about another type of an acne. So this is called the pomade acne, the cosmetica. Okay? So you got small, non-inflamed papules and the comedones in patients who apply products that increase plugging. Okay? So this would be a part of the differential diagnosis of the stuff that we were sawing in there. Location, forehead, temples, sides of the face. So where we have those hair products run down. One of the things that is good about these things, other than of the other types of acnes, is sparing the sebaceous areas, right? So it's not those sweat areas. This is different, so you can have some of that out there. Management-wise, we want to do some of those lifestyle changes. So stop all oils, creams. We can use some of that benzoyl peroxide. We can use some tretinoin. So we know that is yep, good. Inflamed lesions, we can use some of those topical antibiotics. Again, This is at non-sebaceous areas of the forehead, of the temples, of those things there. So it looks like that. It looks like those of the closed of the comedones. That is, in those areas. All right. Now let's get into the WWE, folks. Steroid acne. Okay? Most commonly on the chest, neck, and back. May also involve face and arms. Follicular papules and pustules, uniform size and symmetric distribution, and it doesn't scar, right? So if you stop your damn steroids, then this will go away. I know, right? Clinical presentation, set of nonsense. So 2 to 4 weeks after treatment with PO corticosteroids. Yes, I was making a joke about the steroids, but mostly we can see this if we're giving some of those oral steroids as of a medication, okay? May or may not still be on meds, but they still got it in their system. Teens and adults, often itches, not a contraindication to continued or future use of PO steroids. So it's basically just letting them know that we need to use the corticosteroids. You're gonna get some of the acne, it's gonna itch, but put up with it, okay? So that is out there. Management-wise, we're going to discontinue the oral corticosteroids. So if we can get rid of it, then we can do it. Topical treatment with the benzoyl peroxides and or sulfacetamide or sulfur lotion. We can also use some of those anti-itch things, so of the Atarax and of the Benadryl. Again, like we said before, this should heal without scarring. So that's that steroid acne. We talked about this on like the first day or the second day. Milia. So we have those small epidermal cysts without openings, response to sun damage, other physical trauma, but it's mostly any age. Okay, we see those on of those eyelids. So it's around of the eye. Milia. Same picture there. Tiny white pea-shaped papules, 1 to 2 millimeters in diameter. It is asymptomatic, right? So we talked about how this can happen sometimes with the infants, and of the parents bring them up and be like, is that cancer? Right? Throwing it out there like it's the worst possible thing ever. But it's asymptomatic, solitary, or multiple. Most commonly on the face, especially around the eyelids. You can get it anywhere, but that is the most common locations to where we see that. Again, solitary or few lesions, so we can incise over the lesion and extract contents. Cannot be expressed. It's not one of the things that I want to do for that, right? Just tell them this will go away at one point in time, other than me taking a scalpel and putting it near your eye, and if I mess up, then I'll make you blind. Who knows? Multiple lesions, we can use that retinoid, several weeks until resolution. Okay, so that is milia. Another thing that can be happening with a infant is that heat rash. It's also a similar type of a name, but it's called miliaria. Miliaria. So multiple, diffusely scattered, 1 millimeter papules or vesicles, skin colored, and it's red. So that's different than milia because it's not so much of a red rash. This is, of that redness there. Typically anywhere, but it's especially of those infants on the forehead, cheeks, and trunk. Not only do we sometimes call it a heat rash, but we can call it that prickly heat. Sweat retention. So that could be, yada yada. Hot humid weather, profound sweating, common in babies. So 1 week after birth, they are, wrapped up, or they're held on of a chest, fall asleep, so you can have some of that sweating that is happening in that areas. If they've got some type of a plastic covered mattress, but damn, mom and dad, you didn't cover it up with, something else, so they're just laying in that plastic. And we only really use the plastic so that they don't wet the bed. Again, it'll sting, it'll itch. Treatment wise, usually self-limited. Remove from that warm environment, put it in some cool area, compress, antihistamines, okay, so we can use those things out there. That's what they look like. Looks more like that first of the picture of that infant, but you can see it's not milli that are those white papules. This is miliaria, which is of the red. Hidradenitis suppurativa, okay? These things are, basically you've got chronic suppurative scarring disease of skin and subcutaneous tissue, okay? They almost look like they got some of those bags of stuff sticking out, okay? They can have some of a familial tendency because if they have those scars, but they can have hyperkeratosis over apical glands with secondary bacterial infection. We can see those on the axilla that are there that are causing those. Specifically, to state those locations. They can have it also on their groin, not only on of the suprapubic, but they can also have it on of the anal, which we're going to be looking some pictures of that wonderful stuff. Under the breast, okay, 20s up to the 40s. Female happens, more than males, but it is round and about, okay? Obesity, it's not just going to come and go away. It will, be chronic there, and we could send them to surgical or somewhere else that will, cut it out. It hurts. It can be debilitating. These are those things out there. Morphology-wise, we've got that mild, severe erythema, cyst, abscesses. Okay, it can get worse. It will, in and of itself, start to build some of those sinus tracts, so it can selfly put it out there. Okay. Not only could it be one of a skin like seen in the picture there, right? You can also have some of the comedones, but it's not going to be single ones. It's going to be the double ones. It will be open, so it's the black dots, right? So you get those the blackhead with 2 or more communicating surface openings. Why are they communicating? Because they know how to talk. I mean, right? No. It's because they have that of a sinus tract that is going back in between them. So they're saying, yo, what's up? Okay? Which is exactly what it says right after this. Scarring, healing process, permanently alters of the dermis. So it's not just up on top, it gets all the way down. That's where they have those tracks that can go back and forth. Because of the fact that it's of the dermis, then they can turn into a cord-like band of the scar tissue. Management-wise, the most common, aka major trigger, is smoking. So if they are doing it, then smoking can be one of those things. If you were to ask me why smoking, I don't have an answer for you. I don't know, why exactly smoking does, but I guess smoking messes with everything in the world. Who knows? Mild disease, so long-term antibiotics. So TCNs, Doxy, that's in this one. We're going to do some of those hot the compresses. We can do of an IND. We can use some of that the intralateral steroid injections. So that's if it's just mild. If it's extensive, we already know. I mean, even if it's mild disease, I'm still gonna refer them somewhere out, right? But if it's extensive and they still haven't gone out to see someone, well then I would send them to Derm first, and then let Derm see it, and Derm, send them over to the surgery to have it excised, do some of the grafts. So again, general surgery is the one who will do that, but the dermatologist needs to look at it first and say, I could try this and this and this, but that's not, so I'm going to refer you on. One of those things that a dermatologist would think that they could try first is using some of that Accutane. But who knows if that's going to work. Double and triple. So we've got those of the comedones who have those tracks in between them that could be building this stuff up of an epidermal or of a dermal aspect. So it goes deeper. Saw this picture earlier, so you can see how it looks like an abscess, or it looks like of a kinlog, or just of a cyst that is there producing out, and it's just that. More on of the axilla. If they went to derm and then sent to surgery, that's what the graft looks like. So it's beautiful, right? So they took it out post graft. Talked about how it can happen in of the groin. So we see those on the sides there. Again, all around, so you can see it on of the sides, but you can see it of the abdomen in there. That one right there is on that anal area. So those are no bueno. All right, let's get out of those wonderful pictures. Next, Staphylococcus folliculitis. Again, that last line down there talks about an infection around the follicles by epidermis or aureus. What are the S's there? Good. Morphology, lone or more commonly grouped of small pustules, mild to moderate surrounding erythema. Face around the nares, lower face, chest, or anywhere hair follicles are present, right? So this is just having that staph get into the hair, which causes us to have folliculitis. Associated symptoms, so what else can they be happening other than those pustules that are located there? Well, they can have some of the tenderness. They can have a fever. It's uncommon, but they could have it. Injury related, right? So what was this happening? Well, he was trying to shave all that hair off of his entire body. I said him, but it can be women also. So shaving or other break in the skin, complications of occlusive topical steroid therapy. So that we put them on that kind of stuff, and now it's persistent and recurrent. Well, they probably have that possible nasal caries. So you get that staph up and under your nose, and then it just sheds it out over and over. Skin by contact, so they are having some of the URI, sinusitis. If they're us wonderful healthcare workers that haven't used all of the PPE, if we're seeing some of a patient who's coming in with staph, right, let's protect ourselves. Family members can also, it's just all about the contact. Management, so we can use topical mupirocin or clindamycin, so that Bactroban. If it's extensive, then we're going to get into some of the dicloxacillin or the cephalexin, okay? Why would we go, if it's extensive of Staphylococcus folliculitis, why would we go with cephalexin? Because they have a what? A penicillin allergy, right? So dicloxacillin, if you know that they have a penicillin allergy, then we would have to jump into cephalexin. If it's recurrent or persistent, then we're going to get into Clinda, more dose of that Bactroban, so that puricin into the nares. Wash areas with Hibiclens, change towel and pillowcase daily, because they're just spreading that out there. It's flowing out of them, so that could be causing that there. Okay? Now we're going to talk about one that we have seen in this military for years after years after years. I don't know if it was last semester or the semester before that. I think that DOW, still don't know what we're going to call it, because it always changes. But they actually turned this off to where some of the individuals are not to get of a profile that they can't shave. So apparently men have to shave now. I didn't know that, but that causes this. And why? Because once you do that of an irritation, then that hair goes in and up and under that skin, and then causes it to go on and on and on. So, not sure why they said that, but yeah. Foreign body reaction to hair causes inflammation and chronic distortion of that follicle. So you can see how it looks first, and then it gets pissed off and goes up and under, buries itself, and then you can have the PFB. Razor bumps, tightly curled hair cut short. So we can see all of that jawline and chin are happening in there, okay? 3 to 5% of whites who shave, but most commonly PFB is happening with our African Americans, okay? Profiles for that was something that I wrote many, many times, but apparently now it's going away. Who knows? Morphology, inflammation, papules and pustules, post-inflammatory hyperpigmentation, so it gets darker, scarring, and keloids. Distribution of that beard area. Okay, axilla can also happen of the groin, right? Because we have what at those locations? Hair, right? Management, so let's modify that shaving technique. Hydrate, soften the beard. We can wash it with benzoyl peroxide. We can use some glycolic acid, Aveeno. Shave with grain, or we can get one of those razors that are out there calling about the bump fighter. Okay? I don't know how they work, but yeah. Prescription-wise, we would give some of that topical steroid. 6 and 7 would be what we would use. Those are all the way down at the bottom, so we know that is desinide or of the hydrocortisone. Beard area after shaving, if that 6 and 7 aren't working, then we would have to up in of that 2 or 3, or if they're having some of these larger lesions, we're only going to up it, but if they were to have some of those large lesions, then we would get into the higher dosages. We can add some of a topical retinoid. Again, like I said in the past, we would do a temporary profile for up to 3 months, or we can make it a permanent one. And what would we say? Keep beard neatly trimmed to no greater than 1/4 of an inch, no styling permitted. Laser hair removal can often that. So what do they look like? So it hurts. I mean, like with that shaving, that's that, stuff that's left around being mad and angry. That is like a zoomed in picture that is like, I don't even know, like it's whoosh. Because that's what the hair looks like on, yeah. You can also have it if it's going on in the back of the neck. But saying that PFB can happen in the back of the neck, that doesn't look big, does it? Well, the next one does. Okay? So acne keloidalis nuchae. So it's basically of a keloid that is out there. You get chronic scarring, folliculitis of a known etiology. It'll process the same as of the PFB. It can actually, of the coexistence of the PFB, but this is location specific. So of the neck, nape of the neck, nape of the neck. Says it twice. Occasionally over the scalp it can occur, but the nape of the neck is what we're thinking about this one the most. Management, well, let's not have them have short shaved haircuts. If pustular or exudative, of course, we're going to culture that so we can see what it is that we could use for treatment. Typically, we're using those TCNs. When we go into that 3-step plan for control, we're using some of that topical clindamycin, fluocinolone, and we'll use a retinoid as far as tretinoin. If we're using that retinoid after 3 to 6 months, discontinue the Lytix, which is the one above that, but continue the clindamycin and retinoid for 12 months. Okay? So if it's getting better, then we can get rid of the middle one, but we're still going to keep that up to persist. Treatment-wise, again, we could use some of those oral steroids. We can use some of those intralesional steroid injections. We could send them off to the specialist to have that laser therapy or excisional surgery, okay? If I see these looking like that bad boy, then I'm definitely referring them on. If it's something like this, then okay, I can get into those medication treatments that they just talked about. But if it's getting worse, then I'm gonna refer them on, okay? So there we go. I have never, ever seen one of these where it's inside of a clinic or if I'm at Walmart, okay? All right, we're almost there. EIC, epidermal inclusion cyst. Y'all will see these, I promise. Derived from upper part of the follicle. So it's occluded and also dysfunctional. So it's there. Implanted under the epidermis due to trauma. So something has pissed that epidermal area off, and so this EIC has been there. The follicle becomes filled with semen and swells rapidly, right? So we're going to make a incision on this so that we can get all of that gunk out. But what do we have to do after that? No, we got to take it all out. So we got to get that cyst wall out, because if we don't and everything is out of it, well, up the upper skin is going to close, but all of the cyst wall is here. So we have to excise all of that cell wall out. That has to happen. So again, it'll go all around. If we leave it and it closes, then it's going to fill up again. And then we're going to see them again. Okay? So like what we're going to talk about in block 2 of a lipoma, which is like a soft of a pillow, we have to take all of the wall from that out as well. But this is more of a epidermal inclusion cyst. Round, protruding, smooth surface mass. It can be soft. It can be mobile, so you can move it around. Again, block 2, we're going to talk about a lot of things that you can move and things that you cannot move. Few millimeters to several centimeters, depending on its size. Visible but dysfunctional of a pore. It can have these anywhere, okay? Face, neck, back, scalp, posterior lobule of the ears, scrotum. Like I said before I started to read, everything head to toe. It can occur anywhere. Presentation-wise, typically don't occur until puberty. Most common in people with oily, sebaceous skin, acne-prone, or family tendency for EICs. Typically asymptomatic, but it can rupture if there's all of the inflammation that is in and around it, which with these the EICs, we can see some of telangiectasis that is there with those the cap that can be causing some of that inflammation. If it's not inflamed, then lesions may spontaneously resorb and resolve. But again, resolve, that cyst is still there, so cyst wall, so it's probably going to come back. Sometimes spontaneously ruptures externally. No treatment if asymptomatic, cosmetically acceptable. Removal of non-inflamed lesion along with skin lines. Excise intact if possible. May reoccur if the capsule is not removed. Okay. Inflamed cyst, we can use some of that triamcinolone injection. We can excise post-inflammation. If it's ruptured inflamed cyst, well then excision after the IND. Okay. Incise and drainage is what IND means. There we go. EIC near the eye. I told y'all how it can have some of that telangiectasis. So it'll look like a BCC because BCCs have the basal cell carcinoma. Of the eyes, right, again, so EICs, we excise, so we get that fluid or all that gunky stuff out, and then we go into that cyst wall. That one, I mean, it's not that big, so we could probably have that done in an hour. This one would take days, okay? Yeah. Ugh. All right, last one, pilar cyst. Where's the cyst at? Up there of the hair, of the head. So we've got that pilar area. Multiple smooth, movable sub-Q cyst. Oftentimes it's asymptomatic. 30% of that is solitary, so it's in one spot. They only have one of them up there. Tough lining. Keratinizes differently from EIC. How? Produces a compact, homogeneous material that can calcify. So that's how it's different, right? Location, 90% in the scalp. Less common than an EIC. So an EIC is not in the head and hair area. So that's the difference of them. Treatment, though, is the same. Okay, we want to get that cyst all out. Pictures of that. So it's that one that is up and in there. All right. So that is through of the acne stuff. We talked about anything or talked about everything up there. Started off with that acne. We broke it down into all of the categories of the grading, talking about specific things that are attached to that. We went into everything else that is out there, and each and every one of those things has key facts about them that will make you know that that is what the diagnosis is. Tomorrow, we will be doing the end of block 1. So everything will be presented to you through tomorrow, and then on Monday, then I will be standing up here to do a review. Again, you don't have to be here for that. It's up to you whether or not you want to sit in here. But I will be, so I have of a PowerPoint slide deck built that has all of the pictures that we've seen up here, and it only shows the pictures, and then I just chat about all of the stuff that we chatted about on that, okay? Any questions?